So because this is being live streamed, we should probably start relatively soon. We want to be sensitive to our colleagues at Columbia from time to time. All right, so it gives me great pleasure to introduce the Bronson Ray Lecturer for this year, Dr. Nelson Oyasiku. Nelson, I can honestly say, is a close and dear friend within neurosurgery. And, you know, I don't have a lot of friends in neurosurgery because most people don't like me and I don't like them. But Nelson is a good friend. So Nelson was born in Nigeria, so probably has a fascinating story that a lot of us don't know a lot about. And he's from Ibadan, right? How do you pronounce it? Ibadan, which I looked up and apparently was a city that was founded by warriors, was at least what they say in Wikipedia, and from the Yoruba tribe, which I guess you're a part of. So, you know, you clearly have inherited the tradition of a warrior because you are a neurosurgical warrior. And Nelson has a remarkable history and really is a role model within neurosurgery because he's one of those rare sort of triple threats in neurosurgery who not only is a great clinician, but a great researcher, MD, PhD at Emory, and of course a leader in neurosurgery leadership positions. So Nelson really spent the majority of his career at Emory, where he was rose to be the vice chairman there and ran the Pituitary program, but also had an NIH-funded laboratory looking at the pituitary. And, you know, I remember when I published a paper, and as you all know, I do a lot of pituitary tumors here, and I published a paper on my learning curve with 600 pituitary tumors, and I think Nelson, you know, sent me a text or an email and said, you know, nice series, I've done 3,000, something like that. So, you know, neurosurgery always humbles you, and I'm sure you can imagine the point of the paper was how much I learned after 600. I can't even imagine what an amazing pituitary surgeon you are after 3,000. And I'm sure you get a text from Ed Laws who sort of says, yeah, 3,000's nice, I've done 8,000, exactly. So there's always a bigger fish, right? But Nelson also has risen to the top of leadership positions in a lot of our illustrious institutions. He was chairman of the American Board of Neurological Surgeons, and he was the president of the CNS, president of the Sun, vice president of the Academy, president of the International Society of Pituitary Surgeons and the World Federation of Neurological Surgeons now. And then, of course, the other feather in his cap, as we all know, is that he was the editor-in-chief of Neurosurgery, which is one of the two leading journals, which is an incredibly difficult job. It's amazing that we have two of the past former editors in this room right now with Micah Puzzo. But the fact that he was able to balance that job, which is essentially a full-time job, with his clinical work, which is a full-time job, with the leadership positions and his research is really remarkable and speaks to his incredible organizational skills. And so, you know, as the culmination of just a remarkable career that we all should admire and look up to, he decided finally to become a chairman and is now the chair of the program at UNC in Chapel Hill. And I'm sure we can expect incredible things from that program under your leadership. So Nelson's going to speak to us today about pituitary tumors, which he knows more than anyone in the world except for maybe Ed Laws. So I look forward to hearing about it.
Thank you very much, Ted. That's really gracious and kind of you. And let me first start by saying thank you to the Department of Neurosurgery at Weill Cornell and also the Department of Neurosurgery at Columbia. I understand this is a joint effort from both departments, both of which are legendary in the annals of neurosurgery, and it gives me great pleasure and honor to be here as the Bronson Ray Lecturer. I would also, it's great to be amongst a lot of great friends, Mike, Ted, Mark, and so on and so on, and I know the Columbia department is online as well, and I'm sure I can't see them, but they're all legendary friends and colleagues, and really thank them also for allowing me to be here. In recognition of the fact that this is the Bronson Ray Lectureship, I looked up Dr. Bronson Ray's career, and it's really an outstanding record of accomplishment. Not to bring coal to Newcastle, but to underline a few things about him. He was president of the AANS, and he was renowned as also being Dr. Cushing's last resident that he trained after he did his internship at the Brigham with...
Other one's right on.
Say again? After he completed his internship with Dr. Cushing, he then came to New York Hospital and continued his training here, and actually became the first director of neurosurgery at New York Hospital. He was also, Mike, believe this or not, I'm sure you knew this, I didn't, but he was also chairman of the editorial board of neurosurgery, of the Journal of Neurosurgery, So he was the editor of the Journal of Neurosurgery and ABNS director, and receiving the highest recognition that the AANS could ever bestow on a member, the Cushing Medal. He was also medalist of honor of the WFNS, the World Federation of Neurosurgical Societies, which is a major recognition as well, and honored guest of the CNS. There's more to come. He received the Distinguished Service Award from the Senior Society, and then made some incredible clinical contributions in the surgical treatment of hypertension with sympathectomies. And more to our dear field of pituitary surgery, he was a master at hypophysectomies through a subfrontal approach for then treatment of breast cancer. There was no hormonal treatments and all those things, monoclonals and all that weren't there yet. And pain and progression of breast cancer and prostate and so on were treated by hypophysectomies. My former chair did a lot of hypophysectomies for treatment of prostatic cancer, and that was the way you dealt with the problem, and diabetes. And he did over 1,300 of those, 1,300 hypophysectomies. That's a boatload of hypophysectomies. He was also had his own avocations of woodworking, fishing, and he was a bird hunter. So, I think this is a great testimony to this man's accomplishment, and it makes me even more proud to be here as the Bronson Ray Lecturer. Okay, so I thought that in regard of that this talk I would give would really talk about pituitary surgery and medicine from a different approach, and look at how it has developed over the centuries, really, and where things stand right now. As Ted said, I recently moved from Emory. I'm now at the University of North Carolina in Chapel Hill. So I'm going to talk about evolution and revolution in pituitary medicine and surgery. So what are these concepts first and foremost? Evolution and revolution are both related concepts. They sound very similar for sure. But fundamentally, they describe change of some kind, right? That's basically it. But there's a difference. Evolution tends to be of a gradual, progressive, stepwise, if you will, incremental change. And over time, its effects tends to be long-lasting. Whereas revolution tends to be more sudden, sometimes jarring, if you will, radical. It's looked at as being a dramatic change, typically associated with socio-political upheavals and so forth. And the time scale for revolutions tend to be shorter. good examples being the French Revolution, for example, or the uprising in South America with Che Guevara. So what I'm going to do is cover some of these ideas and discoveries and technologies and some of the people who have played a role in revolutionizing and evolving pituitary medicine and surgery. So if you go back a long ways, for example, way back, the transnasal sphenoethmoidal approach, which we now know and love, that approach to the skull really came about because the ancient Egyptians had to excerebrate the skull before they buried people. So these morticians would use this approach, liquefy the brain, and remove it, and have a nice, clean cranial vault. And this went on for centuries, obviously. The technique as a treatment or as a surgical procedure was abandoned thereafter, only to be resuscitated sometime in the early 1800s. This was about a century before Schloffer actually performed the first transsphenoidal operation. So, and that first transsphenoidal operation by Schloffer was in 1907. And the reason for endoscopy was because there was a need to inspect hollow organs, so things like the bladder, for example, or the GI tract, and so on. And this fellow, a fellow by the name of Philip Bozzini, is credited as being the inventor of the endoscope. The tool wasn't very good at visualizing, at least that particular iteration of it. It wasn't very good, but it was better than nothing. And it was rather painful for patients. But it was a revolutionary tool because it allowed physicians for the first time to see inside the cavities. And then shortly after that, a German urologist, a fellow by the name of Max Nitze, improved upon that early endoscope that you saw by Philip Bozzini. And Nitze's endoscope allowed both light as well as magnification using an internal light. And then there was another variety of it later on called the Hopkins, we'll talk about as well. So the knowledge of pituitary disease really came about in the late 1800s when a fellow by the name of Pierre Marie started writing a lot of papers on the condition which would then become known as acromegaly. And in addition, in the late 1800s as well, a fellow by the name of Minkowski made the causal relationship between acromegaly and hypertrophy of the pituitary gland, which obviously harbored a tumor. But the actual appreciation that the gland was essential to life wasn't made until 1907, when Nicholas Polesko performed hypophysectomy in dogs, and as a result found out that the dogs wouldn't live when you hypophysectomize them. And so that was the first evidence that really the gland was essential to life. In terms of actually doing pituitary surgery, the fellow in this picture, Sir Victor Horsley, pictured here at the peak of his powers, who was a neurosurgeon at Queen Square in London, was the actual neurosurgeon, the first neurosurgeon credited with pituitary surgery as the pioneer. He claimed to have performed the first pituitary operation in 1889. And his surgical experience was limited to about 10 cases, all performed through the transcranial route. And this picture there of this patient is, and his operating room is shown in this slide at the National Hospital for Neurology and Neurosurgery in London. However, on the continent, a fellow by the name of David Giordano, who was a Venetian, and his colleague Francesco Duranti were both important pioneers of approaches to the pituitary via the endonasal route. Giordano proposed this transglabellar horrific approach here that you see, transglabellar transnasal approach to the pituitary based on his cadaveric dissections. And his approach, being the only one that was talked about, was internationally recognized. And he led other surgeons such as Hermann Schloffer from Austria and another fellow by name of Theodor Kocher in Switzerland to then dive in and start doing these similar operations. And later on, Harvey Cushing would adopt this operation and modify it. His contemporary, Giordano's contemporary, Francesco Durant, also developed a transpalatine approach. In parallel, the ENT surgeons were applying endoscopy to the nasal cavity, and a fellow by the name of Alfred Hirschman from Berlin modified a cystoscope to use as an endoscope to inspect the maxillary sinuses. Here's Hermann Schloffer, who performed the first successful transsphenoidal removal via transfacial lateral rhinotomy incision, which you see there, rather disfiguring operation. And he says, this is a quote from him, he says, "The decision to do such a difficult operation as pituitary surgery bears the mark of a daredevil venture." And he wasn't too far off the mark. He was an Austrian surgeon, and of course he pioneered this initial transsphenoidal approach to the pituitary tumor. And he actually also did something interesting. He postulated that the tumor that he removed was actually the cause of the ophthalmological symptom that the patient had preoperatively. So he linked pituitary mass to chiasmatic and optic nerve compression, and resulting in amelioration of the problem. Schloffer's operation was actually guided by preoperative X-rays. He was a pretty fast surgeon. He did the operation in 75 minutes, which, you know, is, even in today's world, is pretty fast. And all his surgery was done at the University of Innsbruck in Austria at the time, and he had no serious complications. His postulate about the ophthalmological improvement was true because he could document it with the improvement in visual fields. And his success in removing a tumor and restoring vision spread like wildfire, such that people started doing the operation. And it was not that far after that Cushing gave his now celebrated lecture to the AMA on the hypophysis cerebri in 1909, 2 years after Schloffer's operation. And it was at that meeting that Cushing introduced the two concepts of hyper and hypopituitarism for the first time. So we're in the early 1900s now, and in the aftermath of Schloffer's operation and Cushing beginning to adopt it, the pituitary surgery market began to advance more quickly as European as well as American neurosurgeons began to develop their own variations of transnasal routes to the sella. And this gentleman, a fellow by the name of Theodor Kocher, he was from Bern in Switzerland, actually proposed a submucosal dissection of the nasal septum in addition to the endonasal route. The reason why this becomes very important is that minor technical variation was actually extraordinarily important because it reduced dramatically the risk of infection, because you'd then be able to put the mucosa back over the septum. And in addition, it expanded visualization to the sella, and also, as you might imagine, the cosmetic outcome was much better. So this innovation by Kocher really took away some of the two major shortcomings of the endonasal transsphenoidal approach by doing a submucosal dissection, preserving that plane, restoring it at closure reduces the risk of infection and cosmetically better for the patient. So that allowed the field to really take off, and people started to do more cases. In that same year that we're talking about, so Coker is in Bern. This gentleman is an ENT surgeon. His name is Oskar Hirsch. He was in Vienna, and so he started to do these operations. He's an ENT surgeon, so he would do the approach and remove the tumor. So one of the earliest ENT surgeons that kind of went off on his own, and he went ahead and performed the procedure by himself, removing a pituitary tumor in a patient who had lost vision. Concurrently, in the United States, Halstead at Northwestern also reported successful resection of a craniopharyngoma, this time by the infranasal transsphenoidal approach, which had been proposed by his colleague, a fellow by the name of Alan Canaveral. Halstead also described the sublabial approach to the sphenoid, which gave a different route. And the reason why that's important is that it took away these facial incisions and also resulted in this better cosmetic outcome. So now we had two direct approaches, one endonasal, one sublabial, both with preservation of the mucosa. This fellow, the same fellow, Oskar Hirsch, also performed the first direct transethmoidal operation in 5 stages over 5 weeks. And he also was the first to introduce the nasal speculum, Oskar Hirsch. And that allowed a wider expansion of the route and kept the tissues away so one could see better. So 1909, 1910, Oskar Hirsch is doing this operation in Vienna. Coincidentally, on the same day, that same day, June 4th, 1910, Harvey Cushing is performing the first procedure with a sublabial incision and submucosal resection of the septum. Both of them corresponded with each other, Hirsch and Cushing. And in 1911, two years later, Hirsch was forced to leave, demonstrated his endonasal approach to Cushing. And in 1938, he was forced to leave Europe because of the political situation. The war was beginning to brew, and he relocated to Boston to practice close to Harvey Cushing. Between 1910 and 1925, Cushing treated 231 tumors by the sublabial submucosal route and was able to keep his mortality rate to 5.6% in an era before antibiotics. So both Hirsch and Harvey Cushing made transsphenoidal surgery the preferred approach for pituitary tumors, and together they did lots of cases. In addition to his classic accounts of acromegaly, Cushing also published right about this time the case of Mini-Me, with the Cushing's patient, and he first described the polyglandular syndrome that, of course, was associated with basophilic adenomas that became known by the eponym Cushing's disease. Right around that same time, there was also the discovery of pituitary infarction by a fellow by the name of Simmons and Sheehan, who then were able to demonstrate that hypopituitarism related to vascular insult of the pituitary gland. This fellow, this Scotsman, a fellow by the name of Norman Dott, is actually a very important man, and you'll see why in a minute. He was Cushing's Rockefeller Research Fellow at the Brigham from November 23 to June 24. And he wrote, as many times fellows will do, he wrote his mentor's surgical experience, and there were co-authors on that. And when Dott went back to England, or to the UK, he returned to Edinburgh, he continued doing transsphenoidal surgery that he had learned from Cushing in Boston, and designed a lighted nasal speculum to augment the nasal speculums that were being used that had no light. And that allowed the surgeon to see deep into the surgical field. For reasons that are unclear, Cushing started to question the transsphenoidal route around 1925. If you read the papers, it turns out that the main quibble that people were having, and he included at the time, was the inability to tell whether they had removed the suprasellar component completely, because there wasn't imaging at that time. They had X-rays, of course, but there was no imaging at that time. So they couldn't tell how far up they had gotten. And so there were cases where patients underwent surgery, had partial decompression, vision didn't completely get better. They would do a transcranial approach and find out that there was residual tumor, lots of it. So he started questioning the transsphenoidal approach, and by 1927, he had made the switch to a craniotomy via the subfrontal transfrontal approach. And since Cushing was a very influential man at the time in neurosurgery, still is, because he stopped doing it, others followed suit. And so what then happened was that transsphenoidal surgery began to fall out of favor, and the problem lasted not 1 year, not 2 years, but about 35 years. So for almost a generation, the transsphenoidal route fell out of favor, except for two prominent surgeons which kept the flames alive, one of whom was Norman Dott in Edinburgh, and the other was Oscar Hirsch, who had moved to the United States at that time and had left Europe. So these two men continued to do the transsphenoidal operation, even though Cushing himself, Cushing the master, had stopped doing it because he felt that it was insufficient for decompression. So here we have a situation where the surgeons have retreated from the transsphenoidal route, and the next major revolution really in pituitary medicine and surgery came from the medical side, largely from the brilliant work of this man known as Herbert Evans. He and his colleagues in this period, in the early 1940s, late 30s, 1940s, were responsible for isolating a number of pituitary hormones at UC Berkeley, notably the isolation of luteinizing hormone. That was in 1940. 3 years later, they cornered ACTH, found out what that did, isolated adenocorticotropic hormone. 2 years after that, they isolated growth hormone in 1945. And then 4 years after that, isolated FSH. So in a period of about a decade, they had come up with the entire gist of how pituitary function did its work by the isolation of these hormones. So an incredible amount of accomplishment in a very, very short space of time. And this is his photograph there, Dr. Evans. In addition, also taking place around that time in the 60s was the measurement, the ability for to measure endocrine function quantitatively by the technique of radioimmunoassay, and that was in the 1960s. The medical revolution continued with this gentleman, a fellow by the name of G.W. Harris, who literally recreated the field of neuroendocrinology. Basically, what Harris did was that he proved that it was the portal system, that the substances in the portal system was the mechanism by which the anterior pituitary function as well as posterior function was regulated. And he demonstrated also that if you section the stalk, you only got a temporary cessation of pituitary function unless you prevented regeneration from taking place. So this knowledge of the portal system, portal hypophyseal system, which is really at the underpinning of the function of the neuroendocrine system, was largely due to the efforts of this man, G.W. Harris. He continued with his hypothalamic hormonal research and was able to isolate TRH in 1966, GnRH in 1971, that's 5 years later, somatostatin in 1973, and GHRH in 1982. So again, the medical people during this lull in transsphenoidal surgery on the surgical side over this 20, 30-year period, a lot of medical advances were taking place and a lot of what would become exceptionally important discoveries occurred then at that time. So perhaps as a result of these medical advances, or maybe in spite of them, the surgeons seem to awaken from their slumber. And there was a renaissance of the transsphenoidal approach, largely due to a few key figures. One was our old friend Norman Dott, and then this gentleman, Gerard Guillot, and another fellow who you'll come to hear about in a minute, Jules Hardy. One of the things that helped also was the fact that in 1957, a fellow by the name of Hirschwitz invented the fiber optic endoscope. So these developments in the rod lens magnifying system and the advances that were taking place in fiber optics were also transforming endoscopy at the time. In 1956, this gentleman, Gerard Guillot, visited Norman Dott in Edinburgh. By that time, Dott had performed 120 transsphenoidal procedures. He had had 0 mortality in his last 80 cases. And Guillot visited with him in Edinburgh and learned the procedure and was very impressed with the outcomes that Dott had talked to him about. He purchased his instrument set. Recall that Dott had invented the lighted speculum and had some other wonderful instruments. And Guillot goes back to Paris armed with Norman Dott's instrument tray and intraoperative fluoroscopy, which allowed Guillot now to use the fluoroscopy to confirm the depth of his instruments. Remember that one of the quibbles with Cushing around the 1920s was the fact that they couldn't tell how far they'd gone. And so Guillot now had this intraoperative fluoroscopy so he could get real-time visual confirmation of the depth and position of the surgical instruments. And he actually operated rather quickly, and very soon he had racked up 1,000 cases and convincingly showed that the transsphenoidal approach was far superior to the transcranial approach. He was even able to lower the operative morbidity and was able to show convincingly the improvements of his instrumentation, resulting in improved visual outcome. Guillot also did something else. He also used the approach for other tumors, not just pituitary adenomas. He used it for meningiomas, he used it for chordomas, he used it for craniopharyngiomas. And in 1961, he reported his technique using an endoscope for both cellular and supracellular lesions via the sublabral transsphenoidal route using the intraoperative fluoroscopy. The only thing was that his endoscopes were still dated. The newer endoscopes hadn't made it out there, so he was using these endoscopes that were dated. They weren't very good with visualization, but he used it anyway and then made the leap from the endoscope to the microscope with Hardy. But they still use the endoscope to look around to examine for residual. So fast forward to this gentleman, Jules Hardy, who was Guillaume's protege and student. Visited Guillaume as a fellow in 1958, and then after spending a few years in Paris, returned to Montreal in 1962, and Hardy would introduce the binocular microscope, and there's the Zeiss up me there that you see there, and wrote a landmark paper in 1971, a technical paper describing his procedure of what was then going to be known as a selective adenomectomy. And that was Jules Hardy talking about the selective adenomectomy. That paper was published in 1971. And he was able to show gross total resection, reliably separating the tumor from the normal gland. And Ivan Chirik, who studied with Jules Hardy, was the first surgeon to perform the first microscopic transsphenoidal surgery in the United States in 1968 at Evanston Hospital in Chicago. And this is the picture of Guillaume and Jules Hardy at the Hospital Foch in Paris in 1961. This is Hardy's seminal technical paper, transsphenoidal hypophysectomy in the Journal of Neurosurgery in 1971. This is the instrument that he used, this hooked curette that you see there, where he comes around the tumor and nucleates the tumor, does a selective adenomectomy using the tumor pseudocapsule, and that's the H&E stain that shows the histological basis for that procedure of a selective adenomectomy, which of course becomes very, very important for the treatment of functional microadenomas. So the indications for transsphenoidal surgery as a result of this expanded to include the functional microadenomas, which now could be cured selectively, and visualization still remained limited because of the straight and narrow field of view. And to address this issue, surgeons would use mirrors and that sort of thing to see around the corners. So this would be an old transseptal microsurgical adenomectomy case that is basically recapitulates what we're talking about with Hardy's concept of selective adenomectomy. Basically, here's the microadenoma in this case, and you can see that this is a speculum because see how that halo of darkness as you go deeper into the wound, which is one of the drawbacks. This is not a lighted speculum, obviously. This is a regular speculum. But that's a selective adenomectomy under the microscope as initially described by Jules Hardy. So to address this problem with light and looking around corners, the next major breakthrough was endoscopic surgery. And obviously this was not specifically for pituitary surgery, but in 1960 there was a gentleman called Hopkins who had patented a system that improved light transmission and image quality within a smaller diameter lens. It also provided a wider field of view. So together, he and Hopkins and Storz went into business together. And in 1965, this German instrument manufacturer, Karl Storz, added cold light source to the fiber optic endoscope, and they began producing the Storz-Hopkins endoscope. They also made improvements in the camera, the CCD camera, and this allowed clinicians to now be able to record and document their cases and so forth, and the improvements in visualization as a result of it. So end of the 60s, fast forward to the early 70s, the big developments in the 70s and 80s were really in imaging. First with CT, being able to provide surgeons with the visualization of tumors like never before. And in short order, within a decade or and a half, MRI had come, and now we could not only see tumors with the CT scan, we could see with the MRI, we could tell invasion, we could tell mass effect, we could tell compartments of tumor and so on. And operative planning and operative execution improved, as did surgical outcomes, of course. So after imaging, the next real development and advance was in the molecular biology of the neuroendocrine system. Basically, we were then able to identify the specific gene products that controlled pituitary differentiation. And you see here the steps from the oral ectoderm through to Rathke's pouch under control of various transcription factors, and then into the lineage of corticotroph through that pathway, and then the somatotrophs, and mammosomatotrophs, and the lactotrophs through this pathway, and the gonadotrophs and the thiotrophs through this pathway. And this knowledge was all driven by the ability of the molecular and cellular biologists to identify these specific gene products that were critical at every step of the pathway in the development of the anterior pituitary. This led to two things: better pathological understanding and a medical dividend in terms of treatment, which we'll talk about. The pathological diagnosis also evolved because immunohistochemistry with antibodies against specific proteins to identify specifically what kinds of tumors, types of tumors we're looking at with immunohistochemistry, and then electron microscopy allowing us to look at the subcellular level came along, primarily due to the work of the group in Canada, and this collage obviously is immunohistochemistry up here, the immunoperoxidase stain against a particular anterior pituitary hormone, and then the electron microscopy as well. In addition, we got better at diagnostic testing. So the oral glucose tolerance test, dexamethasone suppression test, and better means of assaying deep inside with things like inferior petrosal sinus sampling, which was primarily due to the work of Ed Oldfield and his group at the National Institutes. The development of these molecular techniques and gene products allowed us to understand better the pathogenesis of adenomas, with first the discovery in 1990 that pituitary adenomas were clearly monoclonal in origin, and that specific mutations, in this case, for example, in the G-alpha S subunit of the G protein, that is the major driver for growth hormone production and tumorigenesis, was due to a single mutation in a gene in 40% of patients with sporadic growth hormone tumors, and in the majority of the patients with germline mutations, hereditary growth hormone adenomas, such as McCune, Albright, and so on. So that knowledge then later on, as you will find out, led to therapeutics, which has changed the field completely in terms of acromegaly. In addition, more recently, the USP8 mutation, which is the gene product that controls ubiquination and deubiquination of the EGFR, the epidermal growth factor receptor. Turns out that the USP8 mutation is now known to be the causative factor in about 40 to 50% of patients with Cushing's disease. And the mutation in this binding domain of USP8 leads to an inability of that protein to bind, and therefore the USP8 is cleaved, and there's more active protein, which leads to excessive deubiquination and increased recycling of EGFR. The molecular biological revolution, as I said, brought with it a major medical dividend. In 1967, first bromocriptine and then later on cabergoline were brought on stream, and both of these drugs were completely changed the treatment of prolactinomas because obviously with the medical therapy made surgery less useful. And it is interesting that the discovery of prolactin and then bromocriptine were within a couple of years of each other. It was actually very, very quickly after the prolactin was discovered that bromocriptine came on stream, and prolactin was 1971. Shortly thereafter, after the prolactin story, came our knowledge of sandostatin, and also known as octreotide, LAR, which is the somatostatin receptor agonist, and of course that is a brake on growth hormone production, and this led to this drug, which is now available. Now both all the somatostatin receptor analogs have changed the treatment of growth hormone and acromegaly, and all have modified our treatment options. In addition, the growth hormone receptor antagonist, pegvisomant, which again is for the treatment of acromegaly, blocks the growth hormone receptor and is another way of attacking the problem of acromegaly from the receptor end as opposed to the expression of growth hormone end. The important thing about these drugs is that they've really changed the options for treatment, but more importantly for surgeons, they've raised the bar for what we can or we have to be able to show that we can accomplish in terms of surgical remission. In addition, the criteria for biochemical remission and clinical remission have also changed. It used to be, for example, in acromegaly, when I was a resident in training, a patient who had a post-op growth hormone less than 10 was deemed to be cured, which is totally nonsense today. Then it went from 10 nanograms per mil to 5 nanograms per mil. And then from 5 nanograms per mil, then they said, no, we were wrong, it's 2.5. And then a few years after that, the same consensus group said, we're wrong then too, it's 1.4. And I'm sure in the next 3 years from now, it'll be 0.5, something. But the point is that the bar keeps getting raised, and with medical options and other therapeutic options, it means that we've got to be better every time. We've got to be one step ahead of of big pharma. So anyway, the last drug that I think, well, not the last one, but one of the more recent ones is pasireotide, which is also in the same class. So the application of endoscopic techniques came back into vogue. Why was that? Well, it came about really because of something called functional endoscopic sinus surgery in the 70s, late 70s. And so what happened was the ENT surgeons, a fellow by the name of Wolfgang Draff, reported his clinical experience on therapeutic endoscopy of the paranasal sinus. In other words, cleaning out the nasal sinus to improve sinus function, increasing the thoroughfare for secretions, opening blocked routes, etc., removing obstructions, and so on. And this therapeutic endoscopy field just blossomed and started out with Wolfgang Draff, along with other ENTs like Heinz Stampberger and David Kennedy. And they use this technique for the maxillary sinus, the sphenoid sinus, the frontal sinus, the ethmoids. And a new field literally was born called functional endoscopic sinus surgery, or FES as it was known by the acronym. And because of these, the ENT surgeons were getting into every corner in and around the skull base and around the face and head. And it provided the kind of visualization that the microscope could not. And it basically underlined and further exposed the limits of the microscope. And the three main limitations, as good as it was, were A, the light diminishes as the field deepens. Most microscopes are 300, 400 millimeters away from the field, and there's only so much light you can get in there. Second thing is that the light is parallel. It's like straight down a tunnel, which means you can't see around the corner. And for asymmetric tumors and lateral extensions and so on, you have to rely on mirrors and such things and curved curettes and so on, suctions. And then the third thing is that in order to create that space, you need a corridor that stays open. And if you introduce a speculum, then you've robbed yourself of additional light and additional space and additional maneuverability. So it didn't take long for people to put 1 and 2 together to say, well, we got this new instrument we're using for FES, and we got these limitations with the microscope. Why don't we try and thread the needle? And so with the endoscope, the light source is, well, it's right at the target. It's like 2-3 millimeters away from the target, so it doesn't really diminish. And you can go through a small entry, and because of the fisheye lens, you get a panoramic view, and you go from small opening to big view. And, oh, by the way, you don't need that darn speculum anymore. So the speculum, that obstructing the field. So you go from a view like the one on the top with the microscope to the one on the bottom with the endoscope. And so a new field literally is born. So this is a case of a patient with, what is this, an acromegalic. So here's the tumor. I'm just going to show this clip with the endoscope. So this you'd never see with the microscope. The field of view is 3-4 times the size of any microscope known to man. Here we're removing patients with acromegaly, that tumor you just saw, doing a dissection around the tumor. Like most growth hormone tumors, you see it's this white, very, very characteristic white tumor. And what we try and do is here we try and navigate around the tumor and circumnavigate it using the tumor pseudocapsule as our dissection margin. Up there's the arachnoid, you can see. And I like to go from side to side, lateral, inferior, and then superiorly, and then work through that, and then deliver the tumor. And the reason for doing this is, just like Hardy said, is if you do it as a selective adenomectomy, you're more certain that you're around the margins of the tumor, and you're more likely to get a functional remission, particularly if you're dealing with functional tumors. So there's the mass and the tumor removed. Excuse me. In the late 70s, 2 groups reported on the use of the endoscope as an adjunct to the microscope for tumors with extracellular extension. In 1977, that man there, Akpuzo, and his colleagues from USC reported that the combination of these 2 techniques allowed for better visualization of the anatomical, and there's that paper here. It's Apuzzo, Weiss, and Kurtze in 1977, that these 2 techniques together provided better tumor resection. A few years later, 2 years after that, Bush and Hobbs in Germany also published their similar technique in 1978. And so they began this joint efforts of the neurological and ENT surgeons, and that led to the so-called, quote, pure endoscopic transsphenoidal technique, which basically meant that the microscope as an adjunct was jettisoned, and the endoscope as the single visualization and magnification tool was the only one necessary and sufficient. And this fellow, Robert Jankowski from France, reported the first use of the pure endoscopic sublabial technique for cellular lesions in 1992. 3 years later, the next group down, Sethi and Pillay, who were working at the Singapore General Hospital, also described their pure endoscopic endonasal approach for pituitary adenoma. And then shortly thereafter, like a year and a half after, Joe and Corral at the University of Pittsburgh used their and described their endonasal uninostril technique without the use of the speculum. And so we were right at the dawn of the endoscopic revolution in transsphenoidal surgery. So this led to a rapid acceleration of the adoption of endoscopic transsphenoidal surgery. And the indications have continued just to expand by leaps and bounds with the use of other corridors and expanded approaches, as well as technical adjuncts such as neuronavigation, microvascular Doppler, as well as other instruments. And in 2003, Pasquini and Giorgio Frank broke the sound barrier and came away from the midline approaches and got us into the lateral approaches, where we were never going before, through a midline endoscopic approach, and described the transethmoidal, transpterygoid, transsphenoidal approach to cavernous sinus lesions and beyond. And then it was really the dawn of a new era. Going the other direction superiorly, transtuberculum and transplanum approaches, transventricular approaches from below became possible with endoscopes of various kinds and different corridors that were being described and explored by various groups. This is that tumor that you just saw right now. This is a transtuberculum transplanum approach. We're opening the sella, but you can see that the dura itself underneath the ethmoid and the base of the skull frontally is opened, and we're going to open subfrontally all the way forward underneath the chiasm and be able to look directly underneath the chiasm. This is a case of a craniopharyngioma, and we're right here below the chiasm, coming underneath it. The tumor is completely transinfundibular, and it goes all the way into the third ventricle. So once we're below the lesion, separate the margins of the lesion, debulk it from below to allow for more room, and then gently coax it out as we free it up from the walls. And that, again, allows the ability of the surgeon to reach areas where we couldn't have done in the past. With the new endoscopic techniques came some new challenges. It's not a natural transition from a microscope to an endoscope. There's a skill set that needs to be learned. There's a learning curve that needs to be internalized. These tools are two-dimensional images that are trying to take a picture or an illustration, or make an illustration of a 3D anatomical rendition. In addition, the instruments and the manipulation of the instruments around the endoscope and through the nasal passages is a learned technique, and you have to prevent these collisions and obstructions that make bimanual dissection difficult. And so these limitations, this lack of three-dimensionality and the foreshortening and distortions of shape and distance have to be overcome by learning and training. And then with the adoption of better techniques and tools, such as 3D endoscopy and better lighting and magnification, and we're making progress. The last iteration of the improvements that I've seen are the Stort's tip cam, and then the more recent HD 3D images. But it seems that there's been a lull in advancements in the last 4 or 5 years in terms of better technological innovation, and maybe it's time for another technological revolution. So with that, I will stop, and with this little quotation: your life doesn't get better by chance, it gets better by change. So, and I should know I just made a change. So, some questions? Ted.
That was a beautiful overview of history of pituitary surgery. I think it's important for everyone to know from whence we came, because obviously the residents now walk into the OR, you see this beautiful endoscopic view where you can see everything. We're taking out all different types of tumors, and they probably assume this is the way it's always been done.
Right.
It's just the way it's done now, and obviously it's not that way. I know that your practice has changed over time.
Yeah.
I certainly learned from Jeff Bruce, who may be on the listening right now, how to do a sublabial pituitary tumor with fluoroscopy. It's done completely differently
Yeah.
now. You went over the history of it, but maybe you could talk a little bit more about your particular evolution.
Yeah.
How you learned that pituitary tumor, what things changed your practice
Yeah.
the most from your individualistic perspective?
Yeah, very good question. So I was fortunate in that where I trained in Atlanta at Emory University, the chair of the department was a fellow by the name of George Tyndall. And George, one of his greatest passions in life, let alone neurosurgery, was pituitary. He loved the pituitary. That's all he lived for. He did other cases too. He did acoustics. He even did some spine cases every now and then. But his passion was clearly the pituitary. And I think by the time he stopped operating in '97 or something, I think he had done about 2,000 cases, something like that. So he was a real player in the field. He wrote lots of papers and so on. And when I was a PGY4-ish, I think it was, I went to him and I said, Dr. Tyndall, can I talk to you for a minute? I said, yeah, of course, Nelson. He said, I want to let you know what I want to do. I said, what do you want to do? I said, pituitary. He said, oh, okay. He said, you need to stick with me. So I learned from him, and he was a master we did all the sublabial. He also described the unilateral transeptal approach with Bill Collins, he and Bill Collins at Yale, and where you did a unilateral submucosal dissection to the face of the sphenoid, and you opened the speculum. So he described that. And so he did a lot of hypophysectomies, as I said, for patients with intractable endocrine malignancies. And he did a lot of research in primates, measuring portal levels, and so he was an interesting guy. And when I was finishing training, he said he had gone to a meeting. He had gone to a meeting, and he came back and he said he saw something. He said, I need to tell you, this is what we've got to do. It was the endoscope. He had gone to a meeting, and this was in '92, right about when I was talking about the development and so forth. He said, this is going to change the field. You have to go and learn this. He says, I'm on my last mile here, but you need to go learn this. So he arranged for me to go to Penn, where Dave Kennedy was. Dave Kennedy was was a master of this new field called functional endoscopic sinus surgery, and they put up a course. So that it's like almost a 5-day course. So you do 3 days of cadaver and blah, 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 and then you do 2 days where you go to the OR there at Penn and see what they're doing and so forth and so on. The only thing they were doing cranially at that time was CSF leaks. They weren't taking out tumors or anything like that. But I went and I still had the videos for many years. There were these old Betamax videos that we bought for the course, and it was pretty cool stuff. So I came back and I talked to Dr. Tyndall, and I said, I said, Dr. Tyndall, it's different from what we do. And I said, here's what I see. I said, the only question is, it doesn't look like the microscope. It kind of looks odd. I didn't know exactly why, but it looked odd. So he said, let's try it. So we did. We came back and we started to use it on some cases. And we gave up on it after, I don't know what the number was, maybe 15 or 20, as being it was slower, no question. I mean, we could get to the cell in 10 minutes by ourselves. You needed the ENT person, and so on. And it wasn't familiar. You were going from a 3D world to a 2D world. So we didn't use it for very much longer as a primary tool. Fast forward another 7, 8, 9 years, ENT came to us and said, oh, by the way, we're recruiting this young new faculty who's doing endoscopic surgery. Do you want to team up with him? And so we had a meeting and we started to do cases. And we said we'd pick the cases we'd do. The ones that we could do microsurgically, we'd do. We don't need the endoscope. And then the ones that we think we need the endoscope, either as a primary tool or an adjunctive tool, we would use. So we were doing that bit and so forth. And then, we made a clean break about 2008, 2007, something like that, 15, 16 years ago, and we made a clean break. And we didn't cherry pick and do this, do that, and we just made a clean break. And then in the midst of that, about 3 or 4 years into it, I hooked up with some rep who was working with a company called Vision Sense, and the main major protagonist, a fellow by the name of Avi, I got to meet, and he had a tool called the company was called Vision Sense, a 3D endoscope, and it solved the problem of 3 dimensions because it gave you depth perception. So I started to use that and became a major user of it. I did a couple thousand cases with it and became very facile with it, and I used it until they got bought out by Medtronic a few years ago, and they stopped advancing and then started using the Stort's tip cam. So that's kind of like my evolutionary story through it.
Yeah, it's interesting because, I think about, you and Aunt Laws were actually later adopters of the endoscope.
Yeah.
And one of the reasons may have been because you were so good at doing it with the microscope. You were at a later stage in your career.
Yeah.
You were very comfortable and very fast.
Yeah.
And, I distinctly remember a couple of cases. I came here and did sublabial fluoroscopic transplanums for 2 years.
Yeah.
And there were a couple of cases where I got lost.
Yeah.
I wasn't sure where I was with the fluoroscope, and I was
Right.
in all different directions, and I was frustrated.
Right.
And so I went to Bologna in 2003 and took that course from
Georgia Frank. Yeah. Yeah.
Paolo Capabianco was there. And, because I was probably
Yes, yes, yes. That makes a big difference. Yeah, huge.
How to make it fast, how to make it easy.
Right.
It taught me how to do endoscopy. So the learning curve was faster for that reason.
Yep.
It's just sort of interesting the way, depending on how good you get in an operation, you may be less likely to adopt newer things.
Yes.
Someone who may be right out of practice. Necessity is the mother of invention.
That's correct. That's correct.
Something better, and they're more open-minded because the way they do it right now is not so great.
Right. Yeah, no, absolutely. And Exhibit A for that would be the late Ed Oldfield. Dr. Oldfield, may his soul rest in peace, I mean, was reporting Cushing's remission rates in the high 90s. I mean, what else do you want? I mean, do you want it to be 120 over 100? It can't be done. When you have results like that, it's, he's like, why do you want me to change something? It's not broken, I think to your point, same thing with Rudy Falbush. Rudy, for many years, was, just did it the way they'd done it because they got great results. And even till today, Mike Buchfelder, his protege, still does it microscopically. I know a lot of neurosurgeons around my generation too that, they just do it great and they don't need to change.
The other element of the transition that helped was neurosurgery. I mean, the Red Journal was very proactive, publishing enormous amount of endoscopic articles. I mean, you saw that coming.
Well,
That also helped because it allowed everyone to read those articles and appreciate what the Italian group was doing. And I'm sure if another editor's hands, those papers might have been rejected or sent to a third-tier or fourth-tier journal, might not be so.
yeah, no, I think so. Absolutely. I think that.
Thank you for making those points. Nelson, that was never heard anything that was famous.
Oh, thanks, Mike.
Everybody appreciates working and the personal touch. That's a good thing. The comments that I would like to make, especially for the young people, and Ted really alluded to that the issue.
I think in terms of surgical technique, what I would put a lot of stock on is alternate reality, AR, VR, as surgical rehearsal tools, as surgical execution tools, and as surgical learning tools. I think marrying those computer technologies with imaging of the highest order is going to take a surgeon like this and turn you into, something that we have never seen. Imagine, as talented as you are and as experienced as you are, to be able to see and navigate and avoid and reach into, nothing's off limits. I think that's going to make a big difference. I mean, we're not talking cadaver lab here. We're talking real-time computing power and visualization. And I just think that we've got instruments now that we're not utilizing to the maximum effect because we're limited. The instrumentation is not limited, but we're limited. I mean, you can't make knives sharper than what we have. You can't make drills stronger than what we have. But you sure can have difficulty deploying those tools to their limits if there's only so much that you can confidently navigate and see.
Yeah, I gave me the Oculus headset as a gift recently. Meta, it's called Meta.
Mm-hmm.
And I was blown away by what a really high-end
Mm-hmm.
virtual reality goggle can put you into. And I would not be surprised if, not very long, we'll be giving this talk, and basically we'll all be handing out goggles.
Mm-hmm.
And we'll all be in this virtual reality with you, and you'll be walking us through surgery and teaching conferences. Everyone will be wearing virtual reality goggles. And you'll be able to take them through an operation in a way that you've never been able to
Yeah.
see.
Yeah. I mean, superimpose that on imaging, whether it's functional imaging, anatomical imaging, or functional anatomical together imaging at a regional or even near cellular level. I mean, the limits are endless, and I don't know that we're there yet. Yeah, I think there are two elements. I think there's training and there's time, the two T's. Training in that, let's say you want to be a molecular biologist, and all you've been doing is biophysics and systems neuroscience. You're not going to get very far in the molecular end until you train in the molecular end, or vice versa. So I think training is number one. Whatever area of science that you want to go into, training that comes, and then add to that mentorship and so forth. But I think the area that we underestimate the most is time. If you're going to be a junior faculty, mid-level faculty, or whatever faculty it is, and you don't put the time in, you're not going to get the results out. So I think time is just as important as the training, and a lot of times junior faculty just underestimate time. By that I mean you've got to compartmentalize. So if Monday, Tuesday, Wednesday you're seeing patients and operating, well, go get them. If Thursday, Friday is when you're supposed to be doing your investigation or your discovery or your lab, and you're spending that Thursday and Friday, half day in the clinic and 3/4 on the floor and one, it ain't gonna happen. You've got to be sacrosanct about the two things. And then you've got to fight. Then you're not guaranteed, but you've got a fighting chance at it. Yeah, that's my advice. Yes. Oh, lucky you. Yeah. Yeah. I don't think it's necessary. I don't know that it will bring anything new to the field right now that I can think of. I mean, maybe there's something out there, I just don't know what it is, that you can't do with an endoscope. You know, I guess maybe you could come up with something, but I just don't know that there's a lot of it out there that make a microscope necessary. I don't think so. What do you think, Ted? Do you think of anything? I don't think there's a lot. I mean, every now and then in the old days, if you had asked me 20 years ago, when I was doing those cases and splitting them back and forth, you know, there were sometimes when you're doing an endoscopic case and the lens is all messed up and you're in and out and in and out. And, you know, you just go and, because the microscope was in the room, and so we just say, I'm done with that. And that sometimes used to happen, and but that's usually not because of the endoscope. That's because your field is not prepared very well. You know, maybe you need more room, and you need to take this turbinate out, or you need to cauterize the edge of the mucosa there, or you've got a bleeder, or you know, you're passing instruments and bruising them. I mean, you're doing something. It's not the endoscope's fault at that point. So I think for, you know, like I said, in the early days, I might have resorted to change, but now I know a laundry list of the things that are causing the problems. Is it this bone here? Is it the turbinate there? Is it the bleeding coming from there? Is it whatever? And we've figured out, you know, 1, 2, 3, 4, 5, and we can take care of it. And so, yeah.
Before we're done, gives me a great honor.
We got to take a picture here.
Yeah, someone has to take a picture.
Please.
It's on our website. Can you take over the endoscope? Yeah. So this is the official plaque for the 2022 Bronson Ray Lecturer. There's a picture of Bronson Ray.
Oh, wow.
There may be an enlarged cell in there if you look closely.
Yeah, he was probably about to go do a subfrontal hypophysectomy.
Exactly. Anyway, congratulations.